Morning is very interesting miscellaneous case presentations. Now I would like to call Dr. Padmanabhan. He is my teacher and as a chairperson for this session, and Dr. Raman Chawla. Sir, please you also. And I think nobody is there for as a moderator. If anybody interested, you can come and join as a moderators. Now I am, Sir, Dr. Padmanabhan will take over this session. He will.
This interesting case presentation session. First will be presented by Dr. Anantaraman, valve-in-valve TAVI.
Good morning, Chairperson. Good morning, everyone. And I first to thank the NIC CSI for giving this opportunity. Now, most of my training was in UK for 20 years, so that's where my TAVI experience is. And I was there for 22 years. I've come back for the last 3 years. I'm working in Dr. Cherian Foundation in Chennai. Now, the unique problem we have in terms of valve-in-valve TAVI. So this is previously operated patients with a bioprosthetic valve, and you are going to do a TAVI for that. And the unique problem for India and Asia is there are lots of patients who had a smaller valves, a 19 millimeter surgical bioprosthetic valves. So if you go and put a TAVI inside that, you are looking at an inner diameter of around 14 millimeters. And for an adult patient, that's not enough. It's an unique problem for us. So how to solve this? That's what this case is about. So a valve-in-valve TAVI for a 19 millimeter failed surgical bioprosthesis with an Evolute 23, advantage of a supraannular valve. Excuse me. So it's a 61-year-old gentleman, diabetic hypertensive, chronic kidney disease, the usual kind of phenotype. He had an aortic valve replacement with a 19 millimeter perimount bioprosthetic valve with the CABG in 2006. He's from Bangalore, and he had restrictive lung disease and also severe glaucoma with loss of vision in one eye. Now, he had 3 months history of worsening breathlessness, chest pain, and he was reviewed locally. And there was severe restenosis of the previous bioprosthetic processes with the gradients of 100, mean of 65. And he had a coronary angiogram which showed previous native vessel disease but patent grafts, and subsequently CT aortogram showed satisfactory femorals for the TAVI. Now, he was seen locally in Bangalore as well as a couple of centers in Chennai, and said redo aortic valve replacement, especially given previously it was a 19 millimeter, was very high risk, and he was advised to continue conservative treatment. So we saw him, we discussed in our heart team meeting, and we suggested that we will consider him for a TAVI, but specifically for an supraannular valve. So I will show you in the next picture what a supraannular and an intraannular valve, and what is the difference and what advantage this provides. So the decision was to go with a 23 millimeter Evolute or valve-in-valve. So that is a CT showing this sort of inner diameters or 14 by 16. So that is within the previous surgical processes. Now usually we decide the valves based on the perimeter now. We don't decide by the annular size, and the perimeter here is only 50. The lowest perimeter for a Evolute is around 52. So it's even smaller. So perimeter valve for this will be 23. Now when you assess for a valve-in-valve, obviously this is a previously placed surgical valve. It will have a stent and it will have a valve inside. So the inner diameter is what is important. So you are going to put your valve inside that previous valve. So what is this supraannular and intraannular valves? Now the Evolute and core valve is the supraannular valve. and the Edwards sapien is intra-annular, it sits in the annulus. So that it's constrained, the intra-annular valves, it's still constrained. The supraannular valve, it opens above the native valve, so it gives a much larger orifice and a much lower gradient, especially in patients with less than 20 millimeter, which is clearly shown in that picture on the right side. If you have here this one, a small valve less than sort of 20 millimeters, the Edwards valve will have an immediate gradient of more than 40, and a core valve which is supraannular will have a gradient around sort of 20, which is quite acceptable for this kind of valves. And so that is the logic behind why a supraannular valve like this was selected for this patient. So these TAVI steps are very standard. Now you have seen probably a few of these cases. You need to check your femorals. Femoral is good, and then a pacing wire is placed, and then you're going through a 14 French from the femoral, and a check angiogram of the aorta to select your correct views so that you can position the valve, and then cross it with an Amplatz 1 and place your super stiff wire. So this is all standard steps. There is no big difference. And you check your evolutor, make sure it is loaded properly, the pads, as well as there is, all these are parallel, it's not zigzag. Now one of the other sort of issues I have seen, especially in our Indian patients, is taking it through this arch. It's very narrow. You have to be very careful when you are sort of taking your valve through that. And the other issue with this is this angle. It goes and hits there. So we had at least tried 3 times before we can position it, because when it goes, it hits that post, that place. So the technique there was an assistant pulling the wire so that it brings down to the lower part of the aorta and the valve kind of repositions itself. If it doesn't work, then the other thing is to change the wire from Amplatz super stiff to much stiffer wires like a Landacus wire. So on the 3rd attempt, it went through. Once it gone through the post, then it was much easier. So you are aiming for a 3 to 5 millimeter depth there. And immediately after sort of deploying the valve, the system is retrieved. And the next diagram shows there is no AR at all whatsoever. There is no AR. Absolutely fine and fully deployed. And an echo showed a mean gradient of 10 and a maximum gradient of around 15 to 20 immediate post. So the echo at 1 month as well as 3 months, the mean gradient is around 15 and the maximum gradient is around 25, which is quite acceptable for a valve in valve within a 19 millimeter valve. So it's very important, as this take-home message says, when you are considering a valve in valve TAVI, please do take into account all these factors: the size of the previously placed valves, what kind of stent, or is it a stentless valve, how the leaflets will open when you put the TAVI, and consider the supraannular or intraannular. Now, if your center is used to only the intraannular valve, then the only other option is to crack open the previously placed surgical stent. So very high pressure balloon inflation, the stent will open, and then you can put your valve in valve. But that's a much higher risk procedure, better to consider for a supraannular valve. So whether this effective orifice area and the lower gradient reflects into a better outcome, we have to wait and see. Thank you.
Nice, Chris, Dr. Anantharaman. I was just wondering, what was the indication for putting a bioprosthetic valve on the 50-year-old?
The initial
probably it was done somewhere else.
No, it was done.
I was just wondering why at 50 years normally we don't choose a bioprosthetic.
We don't. I do not know whether it was because of his other problems with the glaucoma, vision, bleeding issues, whether they considered that giving anticoagulation will be an issue that might be taken. But obviously it's 8 years down the line. After 8 years he had the degenerative disease. But we will be seeing this. Even now, around 50-55 seems to be increasingly bioprosthetic valve, especially given the TAVI valves are available. It gives comfort for the surgeons so that they don't need to give anticoagulation. Even in Europe it's changed. Previously the cutoff was 65. If you are 65 and below, you get a metallic valve. But now even in Europe it's changed.
Yeah. But the annulus itself was very small. No, naturally these bioprosthetics are more bulkier.
Yes.
So you're likely to have more likely patient prosthetic mismatch.
So they could have probably dilated the root and put a 23 at that time, and that would have been a better option.
Thank you.
In this valve position, are you concerned more about coronaries as compared to routine valve position?
Now the advantage of this core valve it is a concave shaped. So as long as the sinuses are more than 25, it will not. You need to know the type of bioprosthetic valves. There are certain bioprosthetic valves which are stentless, and the leaflets, when they open, it will open into the coronary artery. So this type, like the perimount, where the leaflets are within, it will not be an issue. The minimum sort of height from the sinus to the coronaries is as long as more than 10 millimeters. That's one factor, left or right. As long as more than 10 millimeters, then you are fine.
Distance is important, and the type of basal valve which you use. Any questions from the audience? We need a mic for it, please. Yeah.
The question is, because it's a supraannular valve, is there a risk of stenosis, restenosis of the valve? No, sir. Because the only difference is, rather than opening at the annular level, it's opening about 1.5 to 2 centimeters above the annular, and that's how the valve is made, the core valve. So in terms of restenosis rate, it doesn't affect it. All TAVI valves are bioprosthetic valves. So dual antiplatelet, depending on the center, either 3 months or 6 months we give it, dual antiplatelet. And then you go to single antiplatelet. Anticoagulation, no. At the moment we don't. Yes, my valve is intraannular. It's almost similar to Edwards. How the valve looks, how the delivery system looks, everything is almost similar. So if you are putting an intraannular valve within this 19 millimeter, it will be constrained. The only way to do that is you crack open the previous stent with a high pressure balloon so that it will open up. Then you put a 23, then you will have a nice orifice area. And there are cases, the downside is when you do that, there is a 10% risk of dissecting the aorta and causing aortic. Now, usually all the stented valves, now you have stentless as well as other type of valves, the bioprosthetic valves the surgeons use. Most of the stented valves, you have to crack open it. Now, the advantage of the newer set of valves that is coming up is they are putting in a system where you do a high pressure balloon inflation, it will slide out. So the stent is made in like a sliding system. So when they put it, the surgeons, 23 can be slided out so that it will become 26. And the newer valves are coming up like that.
Thank you, Dr. Anantharaman. I think we'll move to the other case by Dr. Dilip, closure of a Swiss cheese and atrial septal aneurysm with a single device.
Good morning, respected chairpersons and my dear friends. So I will be presenting a case of a Swiss cheese atrial septal aneurysm closure with a single routine ASD device occluder. Now this is a story of a 27-year-old female. She had a history of exertional dyspnea since last 6 months, class 2 symptoms. She had a history of TIA 3 months ago. She had no other comorbidities, and we took her for a transthoracic esophageal echo, which showed a mildly dilated RARV and a multifenestrated atrial septal aneurysm with 2 defects in the aneurysm itself, which was 4 millimeter and 3 millimeters, 4 millimeters inferiorly, and followed by another defect which was outside the aneurysm, which was 5 millimeters in diameter, and the left to right shunt calculated QPQS was 2.1:1 by echo. This was her ECG, and I'll show her X-ray also, which didn't show much of an RV overload, but then we took her for a CAT study to make sure that we need to close this area. Additionally, there was a TIA, so we took her for a contrast echo, which showed some right to left shunt also. So the calculated QPQS in this also was 2.1:1, and so we took her for a ASD device closure. And first we tried to assess the type of the device and the size of the device. So this was her the bicaval view, in which you can see that there's a aneurysm here, and this is another view. I'll just show. You can show that there's a flow coming inferiorly near the IVC rim here in the upper picture, and there's another defect lower down also. Here there's a flow, here in this also, here in this side there's a flow, and along the aneurysm at this point also there was some flow. You can see here there are two flow converging. So we actually measured various parameters. One was the aneurysm, the mouth of the aneurysm, which was 1.5, that is 15 millimeters. The total length from the aneurysmal mouth to the other defect complete, it was 28 millimeters. The depth of the aneurysm was 1.1 centimeters, and the largest defect, it was the defect which was outside, it was 0.5 millimeter. The two defects which were inside the aneurysm, the first one was 4 millimeter, which was inferiorly, and the second one was here, it was 3 millimeters. So at this point we had an option either to put put multiple devices, maybe two devices, one to close the aneurysm or one to and other to close the 5 millimeter defect, or we could use a cribriform ASD device, and with a single device we could have closed. But at that point we measured that the size which we needed to close this was 28 millimeters, maybe 30 we would have needed to close with a cribriform device. We didn't have that size, and we decided to go with our ambulatory septal occluder routine device. So in this the size which we selected was we thought that we will take a 16 millimeter device, that the mouth of the aneurysm, that the two steady points was 15 millimeters apart. So we thought that we will take a 16 millimeter device. The discs of those the device will come out to be 14 millimeters more, 7 millimeters on either side, the LA disc. The RA disc will be around 5 millimeters on each side. So accounting for that, it will the total length of the LA disc will be around 30 millimeters. And once we deploy the device, usually in this septal aneurysm, the IAS is usually floppy. So once we deploy the device, once it stretches the aneurysm, the outer defect, usually the septum will converge, and slightly the distance will shorten off also. So our plan was to ideally to get through the middle defect. Ideally they say either we can go through the largest defect, or we can go through the middle defect, so that it evenly spreads out. But unfortunately we were not able to get through that. So we were just able to get through the inferior defect. We can see here the inferior defect we can pass in. And after that we took our device which was 16 millimeters. We placed it. We initially, before releasing, we just checked for the stability, as well as we just whether there was shunt there. In this we can see that before releasing there is a persistent shunt in the defect which is outside the septal aneurysm. And but we thought that once we release the device, once the tug is over, the device should realign itself, and we are also prepared. If not, we should have we may have to undergo for a second device also. So after that we release the device. After releasing, we can see that the device has perfectly aligned and covered the whole defect. There is no shunt across the superior defect which was outside the aneurysm. And this was the final alignment. You can see that it has completely covered the aneurysm, as well as it has there's no shunt across the septum. So the take-home message is that around 5 to 10% of the patients with second-term ASD are found to have multifenestrated ASD, and even rarer associated with atrial septal aneurysm. The percutaneous transcatheter closure of fenestrated ASD may be more complicated than the closure of a single ASD. It requires careful investigation of the anatomy of the defect and their surroundings. The defects may be closed by the use of one device if the defects are less than 10 millimeters. Some literature say 7 millimeters, or it can be 10 millimeters, or it may require 2 or more devices. When multiple ASDs cannot be closed with one large device, 2 or 3 smaller devices, or some people they perform an atrial balloon septostomy followed by device closure of a single iatrogenic ASD, which has been also has been proposed. But with the atrial balloon septostomy, there is a risk of creating an unpredictable, irregular, large hole. So that nowadays it's not that much recommended. A single regular ASD occluder inserted through the central or the largest device will be stabilized by its waist, and the size is determined by the steady rim, which is the area that it should include usually all the defects. But the waste will also stretch the IAS and bring the surrounding defects in proximity and decrease the size of decrease the total size. Straightening the aneurysm septum may also decrease the size of the defects. Thus, the benefits of using a single device is the shorter duration of procedure, lesser chance of interference with venous flow and AV valve function, and lesser adjacent tissue erosion. But there is a caution: do not oversize the device too much. An oversized device on a floppy IAS may cause tissue dissection and may promote arrhythmogenicity. Another note on cribriform device: cribriform device has a very small stalk which connects its two equally sized rims, and it uses the large disc to stabilize the aneurysmal septum. Only thing is, the device, if the defect size is too large, the device may cruise around the hole to which it was released, and the final positions thus may vary, which was before releasing the position may be different, and after releasing the position may change. If the defect size is large, it may not stabilize it. So, thank you.
Thank you, Dr. L. I think it's a good case, good decision in choosing a single device to close it.
Basically, success of AST closure depends upon the anatomy of the septum. I might have a very small, stupid question. Suppose you forgot aneurysm. Just see the way the tough margin of septum is there. Rest you presume to be a single defect. Then why can't you cover from heart to heart margin?
If the aneurysm was not there.
Forget aneurysm.
Okay.
You have 2 or 3 defects in the aneurysm.
Yeah.
You see the anatomy of the septum.
Okay.
You see the tough margin up, tough margin down. See the distance that, and you presume this is AST.
Yes. Yeah, that can
How
be
does it matters if you take that size of defect and you cover everything together?
Yeah, that is usually, there is only one risk, that it may, the tear of the irregular part, as well as if there is a more pressure, it may tear off in an irregular fashion.
No, I don't understand. You have tough margin up and
Up and
all,
up.
everywhere you have
Yeah.
good margins.
Yeah.
In between there is an aneurysm,
Yeah.
had so many defects. You take one big size defect, device.
No, it is
Presume it to be a big defect, big AST.
if
I'm
it-
talking theoretically, okay? I'm not that expert in this. I'm using it, but not that expert. Why can't you use single device and cover it up?
No,
Yeah,
sir,
there-
the waist is the one which determines the size. No, normally the
Yeah.
waist is very broad here. It will tear off those defects. So it will make it a bigger hole. So probably wiser thing will be to take a cribriform device.
Okay.
That is the problem. If you take a big single size, it will tear off those small and make it into
Irregular,
bigger.
it will create an irregular defect. But there are case reports, there are some case series which they have taken single device for the same, which they have done with
That's what
success.
I was talking with that.
Success. But they have also mentioned that the caution is that it may tear off the defects irregularly, and we may not be able to predict the outcome in some cases. There have been one cases in which it has tear off the rigid portion also, and finally the patient had to undergo surgery. That's a caution there, but usually we can, if there is no aneurysm, we can take it as a whole
then
defect.
it's-
But better to use cribriform device.
One more. How common is dislodgement in aneurysm or without aneurysm? Does it matter?
In aneurysm, if there is a multi-fenestrated defect and we are using a larger size the device, the chance of dislodgement is very less as compared to routine ASD, which has a single large defect. So in these cases, the chances of dislodgement is less.
I have a patient who had dislodgement after 7 years
Oh.
of device. It was regular follow-up. You cannot presume that I lost a follow-up. I'm telling you true. That patient was not being followed up, so when I saw later on he was dislodged. No, I had a patient who was coming to me after every 6 months, and I was doing regular echos. Recent, just couple of days back, I saw that patient, device is dislodged into atria partially, and the residual defect left behind.
Oh.
How do you treat this patient then?
Then probably if the device is free floating, we have
No,
to
it is partially in the defect, partially in the left atrium.
yeah.
There is a residual shunt. And this device cannot be taken back
Retrieved.
because already endophilized. This is already fixed. So in this situation, answer is only surgical tubular device and the recloser. Thank you.
Thank you.